radiotherapy. Well, I'll start. Can everyone listen to me? Can you hear me?
Yes, we can hear you.
Can you hear me? Oh, okay.
Yes, we can.
So we'll start with the epidemiology of prostate cancer. I have some numbers and figures for you. I know it's going to be too much information for such little time, but it's just actually to let you know that 9% of males will develop prostate cancer and 3% will die of prostate cancer. That's what the epidemiology says.
Yes.
And 50% of males over 70 have prostate cancers on cell pathology. So if they die and they do the biopsy of a cadaver, you see more than 50% having suffered of prostate cancer. And in Europe, there are about 240,000 new cases per year. That's about 8% of male cancers and 5% of all cancer deaths. And in the US, the estimates from 2007 are about 220,000 cases and about 27,000 deaths. So for the next slide, please.
Yes.
Yes, for since there are a lot of, I mean, this is about Africa as a continent, so I try to find out some few data, but it is really very limited. We all know the reasons why we don't have enough figures from Africa, right? The data quality is really very limited. But the reported total prostate cancer incidence in Africa is lower than that among African Americans, although we are from the same descent. And the rates are very high or different in different parts of Africa. Within the sub-Saharan Africa, you have rates lowest in the west and highest in the east. That's what literature says, yeah. And the total prostate cancer rates in Africa are similar to distant stage disease rates in the US. And the incidence appears to be rising in African countries. So next slide, please.
Okay.
So prostate cancer is the most widespread cancer in men. About 65,000 men will be diagnosed of prostate cancer per year. That's data from the Robert Koch Institute of Germany in the year 2013. And that's about a quarter of all cancer in men. So we all know prostate cancer grows slowly and doesn't usually lead to death in most patients, as we previously saw. So about 12,000 men die annually of prostate cancer. Well, in the next slide, I tried to find out the mortality in different countries, and you can see the US has one of the highest mortality rates, figures given out, maybe because of the population, because of the diagnostic and good quality of data taking up, yeah. And in Nigeria, we have, fortunately, data from Nigeria is 9,628 cases in mortality. In other African countries, as we know, there's hardly any data. So here I got a chart of the incidence of prostate cancer, well, which is the blue line, which is the blue. Can you go back once more, Credit?
Yes, I'm back.
Can you go to yes? The slide before. Yes, this is just to show the incidence, which are the blue bars, and the mortality, which are the red ones. So just showing, like in the Western world, there's a high incidence, but the mortality rates are really low compared to African or low-income countries where the incidence and the mortality are almost the same. In the next slide, showing the stage by year of diagnosis of prostate cancer, we see in the 80s, there were actually a considerable number of late stage prostate cancer diagnosis and metastatic. But when you continue up to the late 90s, we see that they actually the T3 stage metastatic stage of prostate cancer, which is the orange line, and the blue line down, it's going low, and the early stage low risk cancer patients are seen more. So, and then also another, in the next slide, the incidence estimation from the year 2000 up to 2050, there's a prognostic that there's going to be a high increase in prostate cancer incidence. This also shows in the next slide the case of the UK, the United Kingdom, where you actually see the incidence of prostate cancer, which is the dots above, the gray dots. You see it increasing, and then you see the mortality, which is which are the darker dots, kind of decreasing. So in the next slide, so what's the treatment of choice for prostate cancer? Yes, next slide, yeah. More than a month ago, we had these two options, radical prostatectomy and external beam radiotherapy. Next slide, please.
Okay.
And 10 years ago, we had radical prostatectomy or conventional external beam radiotherapy or conformal radiotherapy or brachytherapy combined with external beams. Those are the options we had 10 years back. And then nowadays, we have all of these treatment possibilities, ranging from radical prostatectomy, nerve-sparing prostatectomy, laparoscopic surgery, or robotic surgery with the Da Vinci method. And then we have the cases of radiotherapy, where you have the conformal beam radiotherapy on the right side, the 3D, the IRRADIATION, VMAT, proton therapy, and then you have the image-guided radiotherapy on the left side, and the surface-guided radiotherapy. And then you have the high-dose conformal radiotherapy, dose escalation treatments, and then hypofractionation, which is also now really common cases. You have a high-dose rate and low-dose rate brachytherapy. And then you have on the left side down in blue, these other complementary therapy methods, HIFU, RITA, ILA, or cryotherapy. So in the cases of radiotherapy, any of the cases of radiotherapy, you could also use androgen deprivation. So for the choice of treatment, there's a really lack of randomized studies. And in cases of radiotherapy, there's lack of pathological assessment, like the stage, if there's capsular invasion, or there's seminal vesicle invasion, or lymph node invasion. And then sometimes there's about 20 to 30% undergrading. So there should be a good selection of patients. You need to know the age of the patient, consider the age and the comorbidities in order to make it a treatment choice. So next slide, please. Can I have the next slide?
Okay.
Oh, there was a graph in between, which before this.
Oh, okay.
I'm sorry about that. And then before again.
That's where we're.
Yes, thank you. I'm sorry about that. So for the treatment of choice, we can see the graph, please.
This is the graph. Right.
Yes, now it's coming up. So for the treatment of choice, you can see for patients between the age of 50 and 69, there's a high tendency of doing the radical prostatectomy, whereas on the right side, patients with 70 plus, they're more considered for radiotherapy options. So next slide, please.
Yep.
Yeah, so there was this the Swedish study. So this is an old slide. The study where almost 700 patients with localized prostate cancer, that's early stage prostate cancer, were randomized in a group having radical prostatectomy and another half having watchful waiting. And well, this is an old slide of 2005. So after a median follow-up of 8.2 years. The next slide, please. You could see, yes, after this median follow-up, you could see that there was, in the group of watchful waiting patients who were below 65 years, like this is the faded line which goes up, compared to the group of patients below 65 years who had watchful waiting, you could see that there was a accumulation of death in the patients, the younger patients with watchful waiting, compared to the older patients having watchful waiting and radical prostatectomy. And taking these two groups of watchful waiting below 65 years, which is the graph on the right, and the ones that had radical prostatectomy, you could see that there was a slight increase in the in death of the patients who were on watchful waiting, death from any cause. So what does this study tell us then in these young patients? That would be the next slide, yes. It tells us that the majority of patients, they have no benefit. They have no benefit. There's actually no difference, because the ones that they lived anyway, even without having any treatment. And in the next slide, shows that the patient that had treatment died anyway of any other cause. So basically, it is just a small amount of patients who benefit from treatment, which is this red curve. Yeah. Well, the next slide we can skip and go to the prostate cancer guidelines. So you can skip this slide because this is just basically telling us what options we have. But let's go to the next slide, which shows us the risk categories of prostate cancer. I think we all know that, right? We have the low, intermediate, and high and very high risk prostate cancer, which is basically according to the T stage, according to the PSA level, and according to the Gleason score. So a low risk is a T1 to 2A below 10, PSA below 10 nanograms per milliliter, and a Gleason of above sorry, that's less than 7. That's a mistake. That's a mistake. It's less than 7. And then intermediate risk is a 2B, 2C, and a PSA between 10 and 20, and a Gleason of 7. And the very high risk is then a 3H and a PSA of above 20 and a Gleason of more than 7. And the very high risk are 3B and 4 and any of the PSA or Gleason scores. So next slide, please. So what are the treatment recommendations? The standard is to do the assessment to know about the life expectancy of the patient. We'll see that later on in the slides. The overall health status of the patient has to be taken into consideration, and the tumor characteristics. So next slide. So what are the managing options like we saw before? We have a prostatectomy, external beam radiotherapy, brachytherapy, or watchful waiting or active surveillance. For the hormonal therapy is actually, for the moment, not a treatment option. Right? This is, as we all know, it's usually alone as a kind of like palliation. So for risk assessment, we have to have the PSA level, the velocity of the PSA, and the doubling, PSA doubling time, the Gleason score, and the tumor stage. So recommendations according to risk factors. For low-risk patients, the options are active surveillance, interstitial prostate brachytherapy, external beam radiotherapy, or radical prostatectomy. And actually, no one treatment modality is preferable for all the patients. So, I mean, you just need to assess the patient, know the general health status, the age, and the life expectancy, and then you can choose any of the treatment options suitable for the patient. For the intermediate risk patient, the treatment options are active surveillance, the interstitial prostate brachytherapy, external beam radiotherapy, in addition to 6 months of neoadjuvant and a concurrent hormonal therapy that's recommended, or radical prostatectomy. So study outcomes, the outcomes data do not provide clear-cut evidence for the superiority of any one treatment. For high-risk patients, we have the options of active surveillance, interstitial prostate brachytherapy, the external beam radiotherapy with the use of concurrent and adjuvant hormonal therapy, or radical prostatectomy. And even here, no one treatment modality is preferable. So it is recommended to do patient counseling, and the studies have shown that a high dose of radiation may decrease the risk of PSA recurrence, and a radical prostatectomy may lower the risk of cancer recurrence and improve survival. For patients choosing active surveillance, the aim of a second-line therapy should be clearly defined, right? Determined if it's going to be curative or palliative, and follow-up has to be tailored accordingly with PSA control or perhaps ultrasound or other imaging modalities. So next slide. So what are the prognostic factors in prostate cancer? We have the Gleason score and the tumor stage. So for radiotherapy patients, the recommended dose should be more than or should be above 72 grays. So we'll come to the doses later on. So next slide. So what are the technical aspects of prostate radiotherapy? Very important, the patient positioning and immobilization. There has to be a rigid immobilization because that decreases positioning deviations on a daily basis. And we usually do in supine position, which is superior with respect to prostate movement. And there's a decrease in number of setup corrections, and it's comfortable for the patient and convenient also for the radiotherapies. And there's also studies that show that there's a reduction of doses to the small bowel, rectum, and bladder. And also very important, the knees, supporting the patient's knees also reduces the doses to the rectum. So I put an image of our LINAC where you can, oh, yes. So that's how we position our patients for prostate cancer in our department. So the next slide. So what other options do we have when it comes to patient positioning and immobilization? Some institutions use the rectal balloon, which is actually a tube which is inserted in the rectum and then filled with about 40 to 50 milliliters of air and stays in position. This should stabilize the prostate. Yeah, so then you have only, it reduces the rectal dose in the sense that the dorsal part of the rectal wall is actually spared. So that reduces also toxicity. But then 1/3 of patients experienced rectal positioning errors, and there couldn't be any reduction of interfraction prostate motion detected. Some departments use fiducial markers for better detection of the prostate, and there's also this hydrogel spacer, which is actually inserted in the space between the rectum and the prostate. So it stays in this area, and then the prostate is then kind of like fixed. There's not much movement then. So how do we do the next slide, please? How do we do the contouring of the prostate? Well, we all know the anatomy of the prostate. In external beam radiotherapy, there's always a problem getting the apex of the prostate. So if you have a CT scan, it gets very difficult to detect where the apex of the prostate is. Some institutions, maybe before, used to use a ureterogram, and then following the bony structures, they would say the apex would be 1 centimeter below the contrast narrowing, right? But then if you have the possibility of an MRI imaging, then it is much easier to detect the apex of the prostate. So next slide, please. Yes, so imaging. Currently, there's a CT scan which is used for the treatment planning, and an MRI is nowadays also very important, because there you can detect the prostate tissue better. So what are the recommendations for the target volume in prostate cancer? Next slide, please. Yes, so for a low risk prostate cancer, that is lower than T2 and glycine below 7 and PSA below 7, you see the CTV is only the prostate. So you control just the prostate. Usually you would, this is from the EORTC recommendations of 2006. So the CTV is the prostate alone, right? And for the intermediate risk patients, as defined earlier, you would want to contour the CTV as a prostate, and then a 5 millimeter margin, and then 1 centimeter margin of the seminal vesicles, right? So in the intermediate risk, you have the prostate and the margin, and then 1 centimeter of the seminal vesicle. That would be the CTV for intermediate risk patients. And then for high risk patients, you You want to contour your CTV, which is the prostate, and then a 5 millimeter margin, and then 2 centimeters of the seminal vesicles. Right. So what this slide just demonstrates how we do our contouring. Oh, we're going a little bit fast. But we contour on our, we always do the MRI and fuse with the CT scan and contour our targets. This is just an example of how we do it. And then our patients get an intensity modulated radiotherapy, IMRT, which is, okay, this is the MRI with the prostate and the margins. So here we have our MRI with, it's usually in our department is 7-field IMRT, and then with the you can see the PTV with the doses, with the 95% isodose. It's on color wash here now. So you see that the margins are really close to the prostate using IMRT, using multiple fields and modulating the doses to the target, right? So, well, after having such good plans, how do we make sure we have we target the prostate on a daily basis? So on the image you can see the technician and the cameras in the room, where she can really not only see the treatment she's doing outside, but watching also the patient in the room, how he's doing. So, but still the question is, where is the prostate? Some people say external skin tattoos and bony structures are not surrogates for prostate positioning, which is also which has been also proven in many many studies, because the prostate displacement is related to respiration, the bladder filling, the rectal filling, the bowel filling, and the state of variation. So in our department, we always advise the patient to have to come with a full bladder and empty rectum. So we really take care of that, and such conditions can usually be fulfilled and better controlled when they if there's a possibility of doing like a cone beam CT on almost like a daily basis, at least for the beginning, right? So there's in the next slide, please. There's quite a number of studies which have shown the set of variabilities during prostate cancer treatment, ranging from a few millimeters up to more than 1 centimeter, which is actually not negligible. So very important to make sure that we don't have these large variations during our treatment of prostate cancer, and this can only be done if you don't only take care of the bony structures, but also know what is going on in the prostate. So in the next slide, I just wanted to show how in our department we put fiducials in the prostate. So this is on the prostate on the right side below. There's a fiducial. We put the urologist put 3 fiducials in the prostate as a guide for us to make sure that we also account for the daily movement in the prostate. So this is one. Another, and the next slide is the sagittal slide to see the fiducial. So what happens when we are doing our treatment planning on a daily basis? Hello. So so the next slide shows how much change can take place. You know, you see, we have these fiducials in the prostate, and then the patient lies on the couch, and the technicians go out of the room and do the portal images, and then you find out this. If we were orientating ourselves only from the bony structures, we would treat the prostate somewhere else. So because we have these fiducials, we match them now to the imaging before, which is going to be the next slide, and then do the corrections, and then we know we are treating the prostate and not somewhere else. All right. So this is about set of variations in prostate. So now coming to pelvic lymph node irradiation, there's always the question when to treat, when not to treat. I guess you all know that already, but I just wanted to talk again about the parts in monograms. I mean, some monograms which can help to get the solution if the lymph node is at high risk or not. So we have the parts in nomograms, and then we have the Roche formula, which you can use to detect. Okay, that would be the next slide. To detect if we are at high risk of lymph node invasion or not, if we have to treat the lymph nodes or not. Some centers, they do the pelvic node biopsy, but it is also acceptable if you use the nomograms to assess if to treat the lymph nodes or not. There is also from the MSKCC also one nomogram, which is on the next slide. Yeah. Also, this is an online tool, so you can go online and give in the data, and then you get the information. So when you decide to treat the pelvic nodes, next slide, please. When you decide to treat the pelvic nodes, there are some recommendations how to treat the presacral region. When you control the iliac vessels, you have to carve out the bowel and bladder and bone, and then you start contouring the iliac vessels from the L5-S1 interspace. And then the external iliac contours, you stop at the femoral heads, making sure of the bony landmarks. And then eventually you stop the obturator lymph nodes at the top of the symphysis pubis. So that was just a rush down of the prostate cancer lecture. I'm sorry about the trouble before. I am Rebecca Buka. I'm actually from Cameroon. I live in Germany already for about 27 years, and I'm a radiation oncologist at the Klinikum Lippe, which is it's affiliated to the University of Göttingen. Thank you very much for listening. So, any questions, or do we proceed to the case I sent, or does anybody have another case we should discuss?
Hello, Dr. Buka. I saw ultrasound guided prostate brachytherapy. I mean, like in one of your slides, it was like ultrasound could be used as a tool for brachytherapy, like as an image guidance for brachytherapy of the prostate. So I was wondering, that's here in the last 3 studies in this review. So I was wondering, could you just say something about that?
Let me see. Yes, there's actually one company, they call it BATCAM. So you install some. So you have to install some cameras with laser in the they call it some cameras in the room, and
I'm going to buy one.
And then, yeah.
No, don't worry. Continue.
Where?
Yes, it is the system is called BATCAM. So actually, technicians can do that. You first of all, you already have your contours of the prostate, which is connected to this ultrasound the machine, and then there's a screen where on the ceiling in the room, where when you insert the ultrasound probe, it matches the images of your CT scan and of your daily planning, and with that you can do the shifting already and do the corrections and treat the patient.
No.
It is actually almost like the cone beam system, only the ultrasound is it has to be manually done at the in the room by the technician or the doctor.
Yeah. Okay. Thank you. So, any question? Question time.
No.
All right. Question time, everyone, please.
Hello.
Yes.
Yes. Hello.
Yeah. Good evening. I'll say it's evening here where we are. This is Dr. Tomi from Luz. I was just wondering, somewhere along the presentation, there was this Swedish study that she showed where the study showed that doing watchful waiting for those less than 65, it really didn't have much advantage over treating them. And I was wondering whether they staged the patient, whether it was a T1 or T2, or was it, it was like a generalized statement. Hello?
Yes.
Okay, can we have this? Can we have the slide again? That was the Swedish study, right?
Okay. Yes, this one, right?
No, yes, and one again, one ahead, one again, another one again, another one again. Okay. Yes, this one, right?
No, I
is it this one?
No. The one I'm seeing here, there's no, not this one. The where you showed, okay, was where you had the graphs where less than 65 had watchful waiting.
Okay. Yes.
Yes, there was a small benefit. There was actually a small benefit.
Okay, this one.
This one, right? There's this small benefit of the patient who had surgery, which is the watchful waiting is the line above, and the line below is the ones who had radical prostatectomy. So you see, there's a small benefit. It just shows that it's a small group that benefits from it, from having treated. Yes.
A small group. But there was somewhere the one before this one where you said they had watchful waiting. Did they have a prostatectomy done? Or it was watchful waiting, and you were saying the one before this was that one. Sorry, please.
Before this, you can go again ahead. I know what you're talking about. Just
before it.
You want another one?
Okay.
Another one. So it was this one, right?
Okay.
No,
yes,
before.
It was this one. Yeah, this one where it was a continuous. The one before, and then when you said that for those less than watchful waiting, for those less than
So let me say it again. The watchful waiting, the curve above, this is for patients below 65, right? And then you see the straight line, it's the patient with radical prostatectomy, also below 65. They are in the same level as the patients above 65, with watchful waiting or radical prostatectomy. So here you see that the incidence of death was a little bit higher with the watchful waiting group, a little bit, and then that is what is shown on the right side. You understand?
Yeah.
The death, there's a small benefit of radical prostatectomy, but it's not really much. If you, as we see in the other slides, there is a benefit of radical prostatectomy, but not really very much, as we saw on the other slides. The difference.
Because I thought, watching it, okay, you clarified it, because I thought said that when I was watching the difference, you said there wasn't really much benefit, so I was wondering.
Yes, there is not much benefit. It's really very small.
I know it's small, right? But what I wanted to find out, I know from here he said it's small, but in this study, it did take, the Gleason score into consideration. He did take the this thing, the PSA and parameter, He did take it into, because there wasn't mention of that. That was what I wanted to find out.
So it was localized prostate cancer. Well, definitely it was low or intermediate risk, but not high risk. It only said I only noted localized prostate. Definitely they took care of the Gleason and the PSA. So they almost had the same criteria. That was according to the Gleason, PSA, and stage.
Because on this graph, it wasn't saying that. He just said,
okay.
Death from prostate cancer, and he just said choice of treatment, which is study. So death from prostate cancer and death from any other cause. So
okay. In the graph before, I said about 700 with localized prostate cancer.
Okay.
Yeah.
Okay, that's just the clarification I wanted to. Thank you.
Thank you. Yeah.
Hello, Rebecca.
Yes. Okay.
Hello, Rebecca.
Hello. Yeah. Hello.
Yeah, please. Thank you very much for the wonderful presentation. I just want to inquire, how often do you do a portal image for your patients on treatment? How often?
Okay. Since we do this fiducial, we do the prostate, we do it on a daily basis.
Okay,
so
on daily
the corrections
basis.
on a daily. Yes. Other institutions who have a cone beam CT, maybe they would want to do the first 5 or with cone beam CT and then continue with portal images. But we do, since we have the markers in the prostate, we do the portal images on a daily basis. Yeah.
Okay. All right. Okay. Thank you.
You're welcome. So am I talking all to radiation oncologists, or I didn't ask before? I'm sorry about that. I wasn't quite sure if everybody on platform now is a radiation oncologist.
Yeah, this is actually the radiation oncology class. Almost everyone here, maybe like 90-something% of persons may be radiation oncologists. I do know once in a while we get non-radiation oncologists in the class. Yeah. So
are we having also others who are already treating on a LINAC, or are we talking only about colleagues who are treating only on a cobalt machine? Are there some doing already IMRT or?
Yes. There's a variation. I think I'll leave that to class to discuss. Some are using cobalt and some are using Linux.
Okay.
Welcome, everyone.
Yes, some are physical.
Hello.
Yeah, I'm Abba from South Africa. I'm a Nigerian by citizen, but
Abba.
Based and practice in South Africa. I just have a few observations, and I just want to share with the colleagues across. I think first of one of our colleagues who asks about the watchful waiting, in view of our setting in the Africa, watchful waiting regarding our patients are not reliable. In most cases, they will come back as a metastatic or either with a cord compression. And as a result of that, I think in most of the time, when we have an intermediate risk or either even low risk, we treat them upfront radically than to wait for them to come back with a metastatic disease. So for that, I think probably, I don't know whether the person who was asking about the question, most likely she was considering our setting in Africa, whereby the follow-up is not actually quite great. Then regarding some of us who are a bit privileged, regarding the portal imaging, hello?
Yes, we can hear you.
Okay, that's great. So regarding the portal imaging,
there was a problem, yes.
Yeah, no problem. I'm the one. Okay. I'm actually working on the screen. Just continue. We can hear you clearly.
Okay, regarding the portal images, here we do, like for us in our center, we do an EPIT, which we do day 1 to 3, and then we do weekly, which we apply it, and reasonably we are getting okay. We are not privileged to use residual markers, but I think within a portal image, it works with linear accelerator, and sometimes we do IMRT, and for some patients we even use a VMAT. So basically, this is our experience, and it's quite, So I believe that we will all have the opportunity and privilege to get a better improvement in terms of the technology.
Yes. Basically, each center gets used to what is comfortable for them, where they feel comfortable in treating the patients, and then that is it. There's no actually one way to impose how to do it best, So it's always the center. They get their own experiences and decide how best they treat their patients. I agree with you. Yes.
Then my last question is that regarding a brachytherapy boost, I don't know how are you people well established with the brachytherapy boost in terms of high risk prostate or intermediate risk prostate cancer? Do you people commonly practice using an external beam and then giving a boost with brachytherapy?
Yes, so actually now nowadays with the hypofractionation and with the developments in external beam radiotherapy, there's not so many centers in Germany who still do the external beam, the brachytherapy boost, the HDR boost, right? Like in the beginning of 2000, when I was in the University Teaching Hospital of Münster, we used to do a lot of this external beam and then brachy boost for intermediate and high risk, yes. And it was actually very feasible, but there's always changes in regimes, and so the recommendations now are actually to do the high dose, to do the dose escalation with IMRT or VMAT, yeah. But it's also possible, yeah.
Sure, thank you.
Hello, Rebecca.
Yes.
Hello. Yeah, please. So I just want to inquire your bladder and rectal protocol. What instruction do you give to your patients so that at least you'll be sure that when they are presenting, they will present with empty rectum and full bladder? I know sometimes it can be funny. I've tried it on my patients, and some will tell you that, well, actually I can't wait no longer. So I just want to learn from you so that at least see the possibility of using it.
It's always very difficult, and yes, very difficult and very tricky. Sometimes, if the patient don't have problems with voiding, right? If they don't have problems with voiding, you can tell them like 30 minutes to 1 hour before they come to their appointment, they can empty their bladder and then drink about 300 milliliters of water, and then don't go to the toilet anymore until they get their treatment. So And for the rectum, we try to treat our patients in the afternoon, hoping that they have their stool already in the morning. It's a little bit tricky. There's actually no protocol. I mean, the thing is that when you use the cone beam CT, then you really see how sometimes empty the bladder is or how distended the rectum is. But it is the problem we see also. Patient compliance, yes.
Thank you.
Hello. Sorry, I just want to just an additional comment.
Yes.
Usman, I think for us here, we have, I'm from Nigeria, and
nice.
From my own personal experience, when we had Alina working, right, it's a bit difficult because we have a long queue. So you really can't say when the patient is coming in for to have the treatment done. So when you say you want a full bladder, some of the things we discovered was that if they have a full bladder, it's difficult. What volume of of urine is in there, right? It varies every time they come.
Yes.
And just like you said, most times because of that age, because most times even they have this urgency. So you find out that before you get them in for treatment, most times they go and void.
Yeah.
So there was this consideration of maybe they should be able to have a reproducibility. Maybe they should be able to have an empty bladder, right? And you now treat because it's difficult. And also one of the things we discussed when Bernard Van der Paul was there, when we went to the National Hospital to meet with some of the things. So like Rebecca said, you have to, assess and study the way your patients, what are the common characteristics among them so that you decide, are they coming in with a full bladder? Are they coming in with an empty bladder because of the long waiting that they have to wait? You can't really say, abroad, you have a lot of machines.
Yes,
and you can say, this patient coming in at 10:20. But you could tell our patients to come in, they're there from morning. And they might be waiting for like about 5 hours or 3 hours before they come in for treatment. So those are one of the things you have to consider. Those are the additional comments I just have to say.
Okay,
thank you. You're right. That is really right. You're right. Thank you.
Yeah, thank you.
Okay.
Thanks. So this is one case, the prostate cancer case. I don't know if you can you still have time to go through it.
Is there time for that?
Yeah, we are short of time though, but you can just go through it.
I don't know if he...
Okay, but you can still go through it quickly. I think it's just 10 slides.
Yeah, okay. Oh, okay. Well, it's just going to be kind of like interactive. So it's, it's a 73-year-old male patient with no significant medical problems. He had a 2-year history of voiding, and he's under urologist attention. So he had a PSA of 8.7 nanogram per milliliter. The DRE was normal. And he got a biopsy. It was an adenocarcinoma, like more than 95% of prostate cancer, a Gleason of 8, and there was a tumor in 2 of 12 core biopsies from the right lobe without a capsule involvement. So do we need any further information? So I go ahead. So this patient had a transrectal ultrasound, and can you continue?
Oh, yeah, I was just suggesting, I'm not sure we need any more information to... Yeah, because we have a very high Gleason score here. And we've had 2 of 12 core biopsy, although no capsular involvement, and then a high PSA. I don't think we need any more information.
Yeah. Me too. I think it's high grade. So
Yeah, this is high grade. Although the DRO is normal,
Yeah.
but that's not
Yes.
diagnostic.
Yeah, exactly.
Okay.
Okay, so the next slide. So the patient had a transrectal ultrasound. Then we have the PSA, the prostate volume, which was 65 cubic centimeter, and there was a lesion on the right lobe seen without a capsular infiltration, and the seminal vesicles were normal. He had a PSA downtime of 11 months, and he had a CT scan of the abdomen and the pelvis. Was normal. So the PSA doubling time was 11 months. So we had a value of 8.7, but before there was already measurement done. So next slide, please. What other tests do we need? So I heard already he was a high-risk patient, right?
Yes.
So are we all right with the bone scan, MRI, or would we say we don't need any more imaging or any more diagnostic?
Well, I think in view of being high risk, this patient is requesting, number one, we did an advanced scan to rule out any bony metastasis, and at the same time, we need an MRI to see that if there are, what is the local level of the prostate, even though we have an information in the ultrasound saying that there is no extracapsular invasion. The MRI can be used for the fusion of the imaging and it's both for staging as well as for fusion. So I have an impression that high risk prostate will be good for MRI and bone scan. That's what we do.
Yeah, so this is actually, it's going to be in settings where all of this diagnostics is possible. You know, there are some settings in Africa where the patient has to pay for all of this diagnostic and treatment by himself, and they would want to keep much of the money for the therapy instead of doing more diagnostics. So you have to always see the setting where you are and what is possible, and yeah, what can you recommend to the patient? Yeah.
Hello.
Yes.
Hello.
Rebecca.
Yes.
Hi.
Are you saying it's not necessary to do the bone scan on the MRI?
It is necessary, of course. Of course, it is necessary. Just thinking of a setting where the patient would like say, I don't have money for the MRI, or maybe there are some settings where there's no MRI nearby. I don't know.
Okay.
Yeah.
We have the facility to do both of them in my
okay,
center.
Good.
Well, in that setting, if you don't have the facilities for bone scan, MRI, you can do skeletal survey using.
Yes. See.
Yeah, skeletal survey.
X-ray, and then you can request for alkaline phosphatase. Yeah, an alkaline level of alkaline phosphatase at least will give you an insight.
Yes. Yes, that gives you an insight to bone metastasis. Okay.
Okay, so this is some information about MRI in prostate cancer diagnosis.
It's quite high.
Well, which shows the sensitivity of MRI, the diagnostic, and its role in prostate localization, as the other colleagues said, in the treatment planning. And where the overall accuracy is about up to 88%. And there you can also detect the seminal vesicle invasion in about 96%, and if there's extracapsular extension. So actually from doing an MRI, you have more information on the patient status. So I would definitely recommend it, like all of you.
Sure. How close is MRI? Okay. How accurate is skeletal survey and using the alkaline phosphates in also trying to dictate bone metastasis for prostate cancer? I know it can be as accurate as MRI, but I'm just asking this because Usman suggested that. Yeah, and I think it's maybe the way forward in centers without MRIs or bone scans. But is it any close to predictive or as accurate?
Well, as for me, I'm not quite sure if there are any studies concerning that. So I'm not experienced in that. I can't really tell. Perhaps a colleague who does that perhaps on a regular basis can inform us. I'm not quite sure it could be as accurate as that because I have no experience on it.
Okay.
I don't think it's that accurate. I believe that it's better we do MRI because I know that yes, there's the issue of financial constraints since the patients pay out of pocket, right?
Yes.
And the only two places where they do bone scan is Abuja and Ibadan. So it's difficult for the patients to tell them, depending on their geographical location in the country, to travel down to those two places. For those who are buoyant, they can, but for those that are not buoyant enough, because we have a lot of people in the villages who never left their locality, at least there'll be somewhere nearby where they can do MRI. Yeah. So at least that would help. But I don't think we can use alkaline phosphatase, like Rebecca said, in terms of, and there's really no studies, and like an additional thing that you can use to probably to confirm, but it's not on its own, standing alone.
Yeah.
You can't really use it to assess that or confirm categorically that there is a bone metastasis.
Sorry, just an observation. I think one of our senior colleagues, Usman, when he mentioned about alkaline phosphatase as well as skeletal survey, as much as I haven't seen a literature, but however, considering the fact that this is a resource-limited area, whereby the access to MRI is nearly invisible, bone scans are not available, instead of considering those cases as a radical, whereas if you can do a skeletal survey and just radiology will confirm that there is a metastasis, that would help to establish the management of the patient. Even though the alkaline phosphatase, there are other disease entities that will bring a rise in alkaline phosphatase. But I think in resource-limited region, it's questionable, but I think it's better than leaving the patient at that stage and concluding to have a decision of the patient as it is. So I think clinically, when you see it, the evidence are quite not that evidence strong, but leaving the patient like this, I would really rather do the skeleton what is the alkaline.
Okay. All right. Thank you. Okay.
So MRI, the role of MRI in prostate cancer treatment planning. We all know that the CT overestimates the clinical target volume by about 34% compared to MRI. And when you use the MRI for radiotherapy planning in prostate cancer, you can reduce the dose to the bladder, the rectum, and the femoral head. So for our patient, are we ready to treat the patient? And if so,
Okay.
if we choose radiotherapy for this patient, I have some questions which I put in the slide, but I think we actually talked about the patient setup, how to mobilize the patient, how about the rectal filling, possibility of using the rectal balloon, and as one colleague said, they don't have the possibility of doing the radio opaque markers, but it is a very reliable way of targeting the prostate on a daily basis when doing radiotherapy.
Oh, thank you.
So on the next slide, we talked about we already heard about the risk group, right? So how are we planning to treat this patient, and what is going to be our target volume? Did we want to include the lymph nodes, the seminal vesicles? What are going to be our margins? Are we going to have a boost? Which technique? Which dose fractionation? So actually the answer to this is on the previous slides. So if we know the risk, we can, from there we can make out our target volume and how to treat. But if I may throw a question in the room, what dose would you give to the patient? What fractionation? What technique?
May I speak?
Yes, please do.
Okay. This patient, considering that have a high-risk prostate CA, we can do a conventional treatment of giving them, treating them in two phases, phase 1 and phase 2, phase 1 to 50 gray and phase 2 to 74 gray. That is a conventional practitioner. However, considering high risk, we usually in our own center we do give androgen degradative therapy for 2 years for them for high risk patients. Then again, we sometimes use hypofractionation. We give them a 65 gray in 26 fraction, and reasonably they have nearly a good outcome. And those are there's evidence-based dose we use for them. As whereas our target is the primary the prostate, including the seminal vesicles. Then at 50 gray, we go down to the prostate. The margin we use is we use an margin posteriorly a 0.760 millimeter margin, whereas the other ones we use centimeter margin. Above all, sorry, we use 7.7 centimeter margins and posteriorly 0.5 because of the rectal dose. We don't do the pelvic knot. We don't do the pelvic knot, and we found it is quite toxic, and the benefit is quite actually not much as we ignored the pelvic knot in those cases.
Okay. All right. Thank you. Thank you very much.
Hello.
Yes.
Hi.
Thank you.
Considering the age of the patient, I'm thinking, would radiotherapy be a form of treatment? On my own opinion, I would think a watchful waiting for his age is 78, and giving radiotherapy in 2 phases, is that not too much for the patient? my opinion.
Hello?
There's a problem.
Yeah, I know. Okay, I think it's set. Okay.
Hello?
Yes, we can hear you now. Hello, everyone. Can you hear us?
Yes.
Okay, thank you very much. So we can hear you, Dr. Rebecca. I think
Okay.
we're almost short of time, though.
Yes, sorry, but I didn't come made the point of the age of the patient. Well, let me say he's only 73, so we need to consider also his life expectancy. He's a high-risk patient. If you choose not to treat the patient, then you need to define what is your goal, with how you want to take care of this patient. Now, do you want to put him on a palliative case, as a palliative case, or because if you don't do anything, you're putting him on a palliative case. We give him only hormonal therapy, I think. But we saw that he's 73, but he doesn't have any comorbidities. He's actually in good shape. So I would really consider, really discuss with the patient, be open to the patient and tell him the options, and then include the patient also in the decision making in such cases. That's my opinion.
Yeah.
If you discuss openly with the patient and he says, well, I still don't want any therapy, then that's okay. But if you're open to the patient and you involve him in the decision making, after having explained to him what is really going on, then I think that's fine. Okay. Right. Yeah. But you need to involve the patient in the decision making. Very important.
All right. Thank you very much. Thanks, everyone. I think our time is up. But I was also...
Oh, I'm sorry.
Yeah, thank you. I just want to suggest also that, we talked about bone scan, what Dr. Usman brought up. I found that very fascinating, and that was why I asked that question. The utility of alkaline phosphatase and, skeletal survey as a proxy in the absence of other imaging modalities to dictate bone metastasis. I don't know. There is no much study on that, which may give us an opportunity to start developing something on that end. We could start thinking of writing a grant up to investigate that. So it's to me a research question. I don't think there is much on that. Okay. Yeah, so someone may just think that.
Okay.
That's good.
Yes. So you
I
can
guess different institutions can try.
Yeah.
Hello.
Different institutions can all look at it, and then we could have, something like you said, an answer to a research question, and it could be published. It will be multi-institutional.
Yes, absolutely.
Yes. So perhaps some have a retrospective data of patients they tested that before. Oh, be good. Why not?
Yeah. All right. Thank you very much.
So we didn't talk about any toxicities, but perhaps in one other lecture into toxicities of radiotherapy of prostate cancer.
Yes. Yeah. Hello.
Somebody's talking, but I can't hear.
Mary Ekbo is talking. It's we have issues with network.
Oh, sorry.
Okay, no problem. Our time is actually up. I think this is something we can continue. Okay.
Okay, thank you.
All right, thank you.
Thank you all very much for taking part of it.
Thank you,
Rebecca.
Thank you.
You're welcome. Thank you too.
Thank you, everybody. Bye.
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 Bye, everyone.
Yeah.